good morning, good morning. Can everyone hear me here? Good? On Zoom? Hope you can hear. Good morning, my name is Jordan. I'm a PGY for this lecture is in the Social Ethics and Palliative lecture series. And so I'm going to be focusing on, this is violence in the ED is the topic, and my specific title is reevaluating how a county hospital responds to violence in the community. So special thanks to Dr. Kendall, Dr. Sim, Berlin, Warshaw, Dr. Christoph, and Dr. Laboyer Rodriguez.
On yours.
Okay. So objectives of this lecture, first three are just kind of like broad. We're reviewing how the city officials have addressed violence in the community, because we're part of the city and we're one piece of it, and we operate based on funding streams. And so kind of reviewing how the city's officials address violence in the community, then moving on to how us as a hospital specifically addresses violence in the community, and then kind of broadening that out to how community-based organizations, some of the organizations that live and operate in Brooklyn or in Manhattan or in the Bronx, how they address violence. And then hopefully we can start talking about building processes to better address violence in our specific community. So just to kind of set the tone, a discussion that we've been having nationwide, worldwide, is that we have kind of this two-pronged issue. We have both violence that is treated with policing, and policing being a solution to violence in the community, and also being its own form of violence in the community, and there being violence that's related to policing. And this kind of became a national conversation after Trayvon Martin was killed. So Trayvon Martin was killed by George Zimmerman, who was enacting a citizen's arrest. So it wasn't quite state sanctioned in the sense that we have a police force and somebody on the police force killing an unarmed person. This is a citizen who's kind of operating somewhere in the realm of policing. And so this happens 2012, and in July of 2013, the acquittal comes, and it's difficult for some people who have been following that story. I know myself, I was a scribe at the time in Atlanta, and I remember the whole hospital was kind of hurt by that acquittal. And so, I was actually talking to one of the nurses who said that Antifa made up Black Lives Matter. And so I realized that, okay, a lot of people don't know where the Black Lives Matter movement came from and why it was talking about police violence. So when George Zimmerman was acquitted, Patrice Cullors penned a letter on Twitter that just kind of went out to people in general saying, hey, we matter, Black people, we matter. And remember that you matter. And that kind of started this whole Black Lives Matter movement between three women, Alicia Garza, Patrice Cullors, and Opal Tometi. And some other groups kind of around that time, 2020, was starting to form. And so then we kind of started documenting this, whether it be socially or, it's kind of documented unofficially. So in 2014, Eric Garner was choked to death. In 2015, Sandra Bland was told, we were told that she killed herself in police custody. Family wasn't so sure. Philando Castile was killed on the side of the road. Jordan Edwards was killed in his car. Botham Jean was killed in his home. And then in 2019, Tatiana Jefferson was killed. In 2020, George Floyd kind of re-sparked this conversation again of police violence in the community. And that was 2020. So the conversation that I think the nation was having was, is police violence a form of violence that's making us sicker? And so you'll see shirts and posters and just lists of names of people who were killed by police. And it's not an exhaustive list. I know I was a former teacher in Baltimore. I know people whose families were killed by police that never showed up on any list that I ever saw. So it's a conversation. So now we have a worldwide conversation on race and policing. And so some of the responses have been systemic. For example, the 8 Can't Wait is a kind of 8 different policies that this group called Campaign Zero believes that can help with some of the police violences in the community. And so New York already kind of abided by 4 of those policies. But there's 4 more. It Can't Wait is a campaign that's going to each city and saying, you know, have you implemented these 8 policies, banning chokeholds, making sure that we exhaust other options before violence. And if you haven't satisfied all 8 of those, how can we get you to all 8? That's campaign 0. So there's systemic approaches to dealing with police violence. Then there's symbolic issues. Jefferson Davis was the president of the Confederate, which was, you know, a move to try to secede from the Union and had to do with a lot to do with slavery. He himself owned 113 slaves, so had a lot of stake in the game. And he's been in Richmond on Monument Ave for years until post George Floyd. This is what the monument looks like now. And I rode by a couple months ago, and it's kind of eerie, but in its own way. Other things, the Redskins are talking about changing their names. First Black president of the NFL team of the Redskins. Not ownership, so I think this might be a little more symbolic than systemic. He's not owner, president. But then we did have some like really good, important systemic changes. Like Nancy Pelosi started wearing kente cloth, and it was amazing. You know, now we can finally talk about justice. And maybe there's a movement to white suburbia. So how does this city respond to violence? Like, what is the response typically? If you have violence in the city, what, you know, and obviously the constituents don't want violence. I don't want violence, none of us want that. So how do we solve this problem? And the city has kind of its own, so yeah. So how does the city respond to violence? Fiscal year 2020, the NYPD had an operating budget of $5.6 billion. And you know, I always, when I hear numbers like that, I'm like, is that a lot? I don't know. It's kind of hard to tell sometimes. New York City pays out about $230 million just to settle some of the police misconduct issues. And so when I ask myself, is that a lot? Well, it's a lot less than $6 billion, but $217 million to pay for all New Yorkers to ride the bus for free. So, you know, the amount of money that's spent to settle police misconduct, $230 million, the amount that's gone towards the whole operating budget, $6 billion. And it's, you know, kind of important to know that that's just one side of how we deal with violence. That's the policing side. The other side is incarceration. And so if we believe that this person or an individual who's committed violence is not safe to be out in the world, we put them in jail. $80 billion federal budget, $3 billion state budget. But important to note, and the reason I kind of play this is because I've gone to Wendy's and I've shopped at Target and I've bought gas from Chevron, all of which are involved in prison. There's about 50 prominent American corporations that have been exposed for using prison labor. They reduce their payroll costs, their overhead costs by using prisoners. And so, like, for example, Whole Foods sold a 12-pound bag of tilapia, and they say from a sustainable American family farm, which is really just prisoners, working for 74 cents a day. So I kind of just, once again, this is the other end of police. We have policing, and then we have incarceration, and incarceration is very profitable. Just something for us to think about. And so $6 billion going to NYPD. How much is that? I'm not sure. I'm not on the appropriations committee. None of us are, budgetary officials, so it's difficult. But what we do know is some of these community-based organizations are starving for funds. It's no accident that when you go to Kavi's website, they've got donate, support us, donate. On the front page, before, nothing else is as important on the front page as donate. That could be that they just are money-hungry organizations, or it could be that they're struggling financially. I think most community-based organizations would say they're struggling. So then it's kind of going back to how we allot funds. I'm not sure if $6 billion is a lot, but I know that in other cities, such as, for example, our own Department of Justice went in and said, is this helping with public safety? Is the police department providing the constituents and those who live there with a safer environment. And what they saw is that basically the police department functions to make money and revenue for the city. And this is our DOJ. This file is public knowledge. Came out 2015 in response to some of the Mike Brown protests in Ferguson. And some of the quotes from this study are saying that the city's budget, city budgets for increases in municipal fines and fees every year. And some of the city officials exhort police and court staff to deliver those revenue increases. And they closely monitor whether those increases are achieved. And so Ferguson police officers from all ranks told the DOJ that revenue generation is stressed heavily on the job. And so once again, this is a money-making institution as well as something meant for us to be safer. And so in New York, we also had our own stop and frisk kind of regime in which the population is 23% Black Americans in New York. There were twice as many stops as Black New Yorkers. So, your average person, you got stopped twice to be searched. Typically, depending on your zip code, it would change how often you got stopped. I imagine where I live, I probably wouldn't have been stopped twice a year, but in other places, they might have been stopped 6 times a year. So those areas, it averages out to twice a year. And so, there has been some studies looking at some of the anxiety and PTSD in youth after they've been stopped and frisked. And I can say myself, I would say I've only had panic attacks during COVID and when wrongfully stopped by police. So last piece about the city is that we've got this new jail program coming in, de Blasio's announcement that we're going to close Rikers, and in order to close Rikers, we're going to spend $11 billion to open up some new jails. Within that, there's a conversation about therapeutic housing units for these prisoners, and possibly they would be housed in 3 to 6 of city hospitals. And so this is, something, the city wrote an article, but this is part of de Blasio's plan, and it's no secret. This is part of him saying we're going to close Rikers, but we're going to open up other jails, including hospitals as places to house patients. And so this is something we should be aware of and and ask ourselves, like, what would this look like? And what sort of healing would happen in this sort of institution? And what sort of healing happens for people dealing with mental health issues in prisons? So that's the city. How does the hospital respond to violence? It's a conversation we've been having as a group, some residents and medical students together, and kind of one of the more important local New York laws, in New York Penal Law section 265.25 says that we have to report any gunshot or burn. Anytime a gun is discharged and that patient ends up in the hospital, or anytime a sharp object is used on a patient that could cause a life-threatening injury, we have to report it to police, and we should. That's part of this is part of what we do. In addition, we report child abuse. We have a sexual self-response team that responds to sexual violence. But for violence in the community, the mainstay of what we are required to do is report to the police. Beyond that, what we do in the hospital, and it depends on our policies, but in terms of what the state requires us to do, is just report. So I'm gonna have like 2 or 3 more thought questions during this, because we're on Zoom and because we're so socially distanced. It's just a question to ask ourselves. What other forms of violence do we respond to in the emergency department? And how do we respond to violence in our emergency department? And how, if we're having a worldwide conversation on police violence, our only requirement is to report gunshot and stabbings. This is my thought process. Okay, so what is EM and healthcare in general doing to respond to this? Nancy Pelosi, what Kente Cloth, what are we doing? We are, or the American Public Health Association has a statement that they gave that's very long, but very informative and helpful. And it's kind of coming out of a 2020 expo they had on preventing violence. And when the George Floyd protests started, they kind of took some of their data and some of their stances as an organization. And they first highlight that since the 1980s, Center for Budget and Policy Priorities has documented that we've had a 26% reduction in 11 of the 13 largest health, housing, and social service block grant programs. And so between 1980 and 2016, $13 billion were reduced in terms of how much money was given through those funding streams, as opposed to a 445% increase in policing or spending on policing between 1980 and 2007. And so what they say, they say that we as healthcare professionals should be working to reduce structurally mediated physiological and psychological violence by law enforcement. This is what the American Public Health Association is saying that we should do as practitioners. To repeal laws that promote or justify increased scrutiny of certain populations, and those be those nonviolent drug offenders, those involved in sex work, homelessness, immigration, and that we should reduce the encounters between law enforcement and those populations. And the last thing they say kind of in that long statement is that, that we should also be doing other things to decrease structural inequities, whether that be in housing, education, employment, mental health resources, and even just interpersonal and institutional factors, or things that institutions can do to support these things. And so like an example is trauma-informed care training for staff in the hospital, and we'll talk about that towards the end. Another group said we urge clinics and hospitals and healthcare providers to review and reconsider their policies and relationships with law enforcement that may increase harm to patients and communities. So this, this radical group is saying that we should reconsider how we relate to police. Anyone want to guess what radical group this is? Yeah. AMA. Says that we should reconsider how we interact with police. Another group saying, let's use our voices to call out racism and hold people accountable. Advocate for policy change at the hospital level, state, and federal. Saying that us as clinicians should spend more time at the bedside, just truly listening to patients impacted by violence and racism. Still a symbolic measure. Truly listening is nothing structural, but symbolic and important. And then telling trainees, or that be medical students, to commit to calling out explicit and implicit bias in the classroom and on rotations, despite whatever fear, and kind of just, expose yourself and don't have fear, just speak up. But a call to be involved in this national, worldwide conversation. Anyone want to guess what group this is? Angela? EMRA, yes, EMRA. Emergency Medicine Residents Association. So that's the city's response, hospitals' response, and EM and medicine in general's response. And what about the stakeholders? What about the people who live in the community and deal with this on a day-to-day basis and have been trying to deal with this since before the protests? CAVI being one of them. CAVI exists not only in the hospital, but in the classroom, in the community. They have days of healing where people who have been involved in, whether they be victims or perpetrators of violence, can come to a place to heal. At UCSF, they have a group called the Do No Harm Coalition. Their campaign issues include street medic training, but also fighting for victims of police brutality, challenging medical institutions, solutions, not sweeps. And what that is instead of trying to sweep the streets clean of homelessness, trying to find solutions to it. And the Do No Harm Coalition actually self-defines themselves as healers, health workers, and activists accompanying communities affected by state-sanctioned violence in our collective struggle for health, dignity, and sovereignty. Another community-based organization being the Coalition for Concerned Medical Professionals. They are down Remsen, 1542 Remsen Ave, on the corner of Remsen and Avenue J. Right here is Miss Elizabeth Stevens. She's been working with them since 1973. They, as soon as I met them, they told me that all the different doctors they worked with, including Dr. G, Dr. Mandeville, if you know, from OB-GYN, and Dr. Dees, who's like he's a part of Downstate's history. And so a lot of, so this is a group that's been here for a long time, trying to answer questions and solve problems in the community, including violence in the community, trying to help solve that. In addition, they recognize that violence in the community stems from structural inequities, and people are more violent when they're struggling. And so one thing that they do is they advocate for uninsured patients who have been denied care. They were telling me about a patient who the doctor said that they would recommend hyperbaric oxygen, but there was no way for the insurance company to pay for it. They help them navigate it. They're patient navigators. And in speaking with them, they said that we can work with them, and they have a phone line for their patient navigators who can help. And so what they've said is that a lot of patients who, in this time, who are struggling, or some of the patients who have come to them have said they've now reached a point where they're going to have to do something else to survive because their medical bills from COVID have derailed their life. And so this is something that, what they've told me is that it's pretty easy to try to get insurance companies to try to find ways to get patients' care covered for COVID, but you need somebody to help you out. You need somebody to help you navigate the system, and that's what they do. In addition, kind of instead of broadly looking at all the things that contribute to violence, there's kind of centering on violence itself. There's a word that I think we should be aware of now is restorative justice. And restorative justice is an alternative to incarceration, saying that there are other things we can do than spend billions of dollars housing individuals in prisons. And so what they do is they work through local solutions. This common justice initiative is in New York. This is a New York, almost everyone who I'm mentioning is a New York-based institution except for the New York Harm Coalition. But they're in New York, and they work for both the victims of violence as well as perpetrators of violence, to try to avoid incarceration or reduce incarceration and help people get back into society without having to pass through. CommonJustice.org is one place you can look them up, and restorative justice is just a term that we should in general be aware of. There's even a restorative justice initiative. It's a whole different group in New York who work to, they say that they're practitioners and advocates and community members who all increase support for those who perpetrate as well as suffer from violence. And that's not an exhaustive list. Safe Horizons is a group that social work kind of introduced me to, but outside of that, we've got the NYC Anti-Violence Project. Project Reset is a group that's specifically in the Bronx, but what they do is they try to do conflict mediation in the community before things become an issue. At Sign Out yesterday in CCT, we had a patient who was shot dead, and the family came in, and they were visibly upset, crying, but in addition, talking about retaliation right there. And so we as practitioners see this, we know this, but what are we gonna do? Are we gonna go out and try to stop the retaliation? No. Are we gonna try to call the police and make the police aware? Maybe, and maybe that's what we do, but is that the only tool we have in our toolbox to deal with this violence? The Door is another group that specifically helps with housing, community counseling and meditation. Rather than conflict mediation, sometimes it's an individual who has poor access to mental health services who just needs somebody to on the spot come and help out. And that's what CCM Brooklyn does. And the Spirit of 1848 is a group that kind of branched out of the American Public Health Association, and is another group that's practitioners, public health officials trying to take a holistic approach to violence in the community. So what can we do to try to shift and address violence? Kind of when we talked with the EMRA saying that we should, or AMA was saying we should employ institutional factors or changes to institutions to make sure that we're addressing violence. One of them is training staff in trauma-informed care. Just like restorative justice, I think trauma-informed care is a buzzword. Just like in medicine, we hear, you had warfarin and then you had the NOACs, and all of a sudden everyone's saying NOACs. It's such a common term, it's something you should know. I think trauma-informed care is a term we should know as healthcare professionals, and restorative justice as well. And trauma-informed care, we've got these 6 guiding principles, but I think to sum it up, it's meant to create a workplace that's responsive to trauma rather than just reactive, and proactive around creating an environment that's respectful to those who have experienced trauma. And I think the hardest part about trauma-informed care from my research is that part of what it's meant to do is provide choice to the people you're serving. And so trauma-informed care is brought to schools and clinics and hospitals, but in the hospital, choice is a difficult thing because we are the experts and patients oftentimes the education gap. So it's something for us to maybe consider and maybe grapple with, and maybe even cater to our own needs. But there are vendors who come to the city to do trauma-informed care. We're talking to Dr. Mehta about creating a budget around bringing trauma-informed care to downstate, and maybe possibly to Kings County. In addition, like the AMA said, we should reconsider how we interact with police and with law enforcement. And so one thing kind of did things, the artist in the residency program, is she kind of put together a poster just kind of outlining some of the research residents and medical students have done surrounding how we interact with police. And typically, police will come ask us questions, we answer those questions, we move on. Or police have a patient who's under arrest and they're there, and we may ask them to switch the cuff to the leg so that way we can examine the wrist. And that's typically the interaction that we have. But anyone who's worked on shift also knows that police will interrogate patients, will confiscate materials, and it's important for us to ask ourselves, is this a violation of the patient's dignity, 1, 2, rights, and 3, does this violate HIPAA? I realized that I've been violating HIPAA for 3 years by kind of talking about patients' PHI with the police officers right there. They don't have to be within earshot, they can be within eyeshot for your safety. If you feel safe, if your staff is safe, you can ask the police officer to step away and continue to be within eyeshot for safety, but not necessarily within earshot, because that would be a HIPAA violation. And so, asking ourselves some questions: can we dismiss NYPD from a resuscitation if they're obstructing care? Another issue that's come up often is, can patients go into custody with medication? It's something for us to know and have clearly outlined. And then, can you as a provider insist police remove handcuffs? And the answer is yes, and that's spelled out in the law. They may ask for a safety assessment, and you have to comply and make sure that it's safe for your staff and other patients to remove the cuffs, but that's you as a practitioner can request that. So, just kind of wrapping up, I think moving from what do we do to respond to community violence, from what could we do, and then hopefully in the future, what are we doing? It's just a question that I'd like to pose. Some rhetorical questions that I ask myself along the way is, how many people are actually killed by police? Like I said, I know people who have been, I know family of friends who have been killed by police who never show up in any list that I've ever seen. And I think it's important for us to get data on a lot of these things. How many times do we call hospital police? I'd be interested, because maybe that data could help us respond better. Maybe that data could help us understand what are the situations in which hospital police are called more often and violence erupts in the heat. I ask myself, aside from murder, whether other forms of violence do police enact. What would be the cost to society if we didn't prioritize policing as much? Rhetorical question. What would be the cost to society if we abolish policing as much? And what's the current cost to society given our own hesitancy to abolish policing, or maybe abolishing policing practices that contribute to violence? So, kind of, once again, wrapping up, my last objective is seeing if we can build processes to be a part of this worldwide conversation in which at the moment, there are things happening, but the only thing that we're required to do is this reporting. And I think we can do a lot. But yeah, any additional questions, rhetorical or not?
I've had instances where police officers are like at bedside and they're antagonizing patients, or I'm literally doing the same thing, like getting history and talking about extensive details with the patient. So is there a place I can reference that has like these policies outlined? Because I've had situations where they're saying, no, I can't do this and I can't do that. And it seems like they are obstructing the patient's rights.
Yeah, so we've kind of like copied and pasted some of the like New York State penal law into like a Google Doc, and I can send that to you, but then I can also just kind of give you the where we got that data. Right now, I'd like kind of the working group that was working on gathering this data wanted to run some stuff by legal aid, just to make sure we're not missing anything. And we did kind of unofficially, but we'd like to get some more opinions. So I'll send you those, and then if I can blast it up to the group for that data that we collected, and then we can also maybe return to that conversation and make sure that we're doing it.
I had a patient that was arrested by NYPD, and as I was evaluating him, he wanted to speak to his mom. And NYPD interrupted me and saying he's not allowed to talk to his mom, not allowed to talk to his family. Like, how should I didn't know what to do, so I just didn't give him the phone to talk to his parents or his mother. Like, how should I have handled it differently? Like, what's the protocol for that? Because technically, so he was arrested by NYPD, but he came in for just medical clearance or something. And he wants to talk to his parents, or his mother rather, to let her know that he was arrested. And when I was about to get the phone, NYPD stopped me and said that I couldn't give him the phone.
His phone or like
just like a regular hospital phone, yeah. So I didn't know how to handle the situation, so I just didn't give him the phone. But are we allowed to do that? Are we not allowed to do that? Just the attendings are to you.
I mean, like I've really gotten into the weeds of this stuff. I still don't know. I mean, I'm not sure. I'm not sure, and I think that's part of what this is. We should have a better understanding for how we do interact. Because although I have a million of those stories, I also have times when I'm really glad that NYPD was there to streamline some of our reporting processes, especially around like some SART cases. I'm very glad you're here so that this can get documented and this person can get justice, hopefully. But there are times when I feel very uncomfortable. And so anytime I say I don't know, that means we should maybe have some sort of internal conversation about how we interact.
Any more questions? Okay, thanks, Jordan.
I'm glad you mentioned SART, because that's actually one important thing that I had a conversation with recently with one of the rotators, because there was some miscommunication between the nurse and the SART nurse that wasn't there and the patient in terms of understanding what their rights are and what they're obligated to do if they come in for a SART exam. So if you have a patient that comes in and they elect to get the SART exam done, they do not have to interact with police in the department. They do not have to interact with NYPD in our department. The New York State Department of Health law that governs the way that the SART kits are done says that someone who's certified, like yourself or SART nurse or whatever, does the kit, and the chain of custody should be clear, and then that should be handed over to the local precinct where this issue happened, or where the supposed crime happened, right? That doesn't mean that the police officer has to speak to the patient if they don't want to be spoken to at the time. It doesn't mean that the patient has to be given an ultimatum to file a report or make a decision about whether or not they're going to file the report on the day that you do the SART exam. Okay? Very, very important that you clarify this to the patient, especially because a lot of them are younger, right? Like girls, sometimes they're like 18 and 19, they don't know anything. So if they get just bombarded by a bunch of information, they'll be kind of stricken and they won't know what to do, and then they'll just automatically back away and they say, no, I don't want to do it. But the state law basically says that you have up to 96 hours to collect the evidence. After 96 hours, you can't collect that evidence anymore. It won't be admissible for them in court. So usually you try to convince them as much as possible to get the kit done, and then the state stores it for decades. And whether or not they decide to file a police report, that's their prerogative to do later. But no one, SART nurse, other nurse, otherwise, should make the patient decide whether or not to report them, or make the patient talk to police in the department either. It's a safe space for them. All they are guaranteed and entitled to are the medical examination, all the medicines, the HIV stuff, the contraception, and all that good stuff, and to get the exam done. And then if they want to go home, they get to go home. They can file the report a year later if they want.
Awesome. All right, thanks, Jordan. Let's just take a few minutes and we can get our next lecture.